Our guest today is the Executive Vice President, Strategic Affiliations, and Associate Dean of Community-Based Research at the University of Chicago Medical Center. He is a native of Chicago and received his undergraduate degree in chemistry from Grinnell College in 1987. Our guest today earned his master's degree in public health from the Harvard School of Public Health in 1991 and his medical degree from the University of Chicago in 1993. Ladies and gentlemen, please welcome back to the City Club of Chicago, Dr. Eric Whitaker. Doctor?
I was going to say good afternoon. Good afternoon. Okay, we need to have a little spirit in here. First of all, I want to thank Jay for that introduction. I can't compete with Jay in terms of recognizing and shouting out folks, but I must take the prerogative to do just a little bit of that. First, I want to also thank President Emo Jones for being here today. I call him the original president. So I want to thank he. And also his wife, Dr. Lori Stone Jones, who did a phenomenal job, or does a phenomenal job. We also have a number of representatives here from the University of Chicago Medical Center. We have our Board of Trustees members, and I believe Ken Sherrigan, who's our president, is here. I also want to recognize my pastor from a church you all have never heard of, Pastor Otis Moss from Trinity United Church of Christ. And there are a number of people with whom I worked side by side at the State Health Department, the Illinois Department of Public Health, Rory Slater and Quinn Golden, who now works with me at the University of Chicago, as well as my successor, Dr. Damon Arnold. And I just close out by recognizing my family. My two brothers are here. My older brother, Larry, who always says that I'm the oldest because I have the most gray hair. And my younger brother, Mark. I want to thank them for being here along with my sister-in-law. And finally, my wife, Dr. Cheryl Whitaker, who is here, as Jay mentioned when we were talking about introductions, he said we all marry up, and I want to agree with that assessment. I did tell Jay that I'm going to talk a little bit about medical student debt, and one of the things I didn't do that I promised myself was marry someone with more educational debt than I had. So my wife actually outstripped my debt level, which was extremely high, and so we were happy to pay that off, I think, 2 years ago. That was. So as I look out around the room, there are friends. I have some folks here who were friends in grade school. Through now, fast forward many years forward to this time with my work at the University of Chicago. And, I really feel like I'm here among family and want to just really share some thoughts about the Patient Protection and Affordable Care Act, which many of you all know was recently signed into law by President Barack Obama, and how this centerpiece of national healthcare reform will support efforts to make healthcare services more accessible to underserved populations. I will focus my remarks and observations on the south side of Chicago because that's where I'm from, and also where I do my work. Where for nearly the last 3 years, the University of Chicago Medical Center has undertaken something called the Urban Health Initiative to help Southside residents access quality care, health care, and improve their health. For many of us in the public health field, March 23rd, 2010, the date President Obama signed the health care reform bill in the law, marked the culmination of many years, even decades, of advocacy on behalf of citizens who had been shut out of the American healthcare system. My personal involvement traces back to 1991 when I testified twice before the U.S. Congress on national health insurance and minority health issues on behalf of the 30,000 members of the American Medical Student Association, where I was serving as its national president. This and other early experiences in my career opened my eyes to the tremendous inequities in the American healthcare system, inequities we're still working to address today. My past experiences as an attending physician at Cook County Hospital and as director of the Illinois Department of Public Health, as well as my present position leading the Urban Health Initiative, has given me a front row seat for viewing the challenges facing medically underserved populations. Fighting for reforms to help these populations has always been an uphill climb, and this most recent historic effort was no exception. After passing the first House and Senate bills in late 2009, meaningful health care reform looked really promising. Little did we know at that time, some of our biggest challenges were yet to come. Sadly, losing one of the biggest proponents of health care reform, Senator Ted Kennedy, and subsequently his Senate seat, was stunning to those of us who had taken 2 yes votes from Massachusetts for granted. As was widely reported, there was a great deal of debate within the Obama administration about how to proceed once it was clear getting 60 votes in the Senate was no longer possible. You know, I must say optimism was in short supply, and our opponents smelled blood in the water. I was present in the chamber at the joint congressional session address when President Obama began his efforts to revive the health care bill many had already pronounced dead on arrival. I heard Representative Joe Wilson shout, "You lie." And, you know, we were going to try and deal with that South Side style. But, you know, I was sitting in the First Lady's box and had to comport myself in a little different manner. But he shouted at the president as he refuted misperceptions about the bill before a deeply divided Congress. There were doubts about success all the way until the end. In an email exchange just one day before the vote, the president told me that we were still 2 votes short. On the eve of the historic vote, it still didn't look like it was going to get done. But we prevailed, thanks to the courage of many House members who voted yes despite possible negative career ramifications. Thanks to their courage, I stand before you today to tell you that this new legislation will have a positive impact on this nation, on Chicagoans, and indeed on those I work with and for, the underserved populations on Chicago's South Side. It's always interesting to me to hear the broad, varying perceptions that people have of healthcare in America. In some quarters, we hear that America has the best healthcare in the world. You often hear that, America has the best healthcare in the world. That may be true for those with the ability to pay or for those with generous healthcare benefits, but for more and more Americans, getting access to the best healthcare in the world has been an elusive exercise. For many, the healthcare system here is operated on a par with a system you might find in a poor developing country. Earlier this year, I attended the World Economic Forum in Davos, Switzerland, and was present at a small session where we had Bill Gates, Michael Dell, Cisco Systems CEO John Chambers, and other technology heavyweights discussing the outstanding potential for technology to improve healthcare efficiency and outcomes. At one point in the discussion, they talked about how healthcare technology could really make a difference in improving health in developing countries. I literally raised my hand and said, developing countries? How about doing this work on the south side of Chicago? That one question has led to explorations between the Urban Health Initiative and a number of our country's largest technology companies with the hope that we can accelerate an improvement of health status on the south side of Chicago. So you see, from my perspective, I see the best and worst of American healthcare with only a few blocks, within only a few blocks on the south side. I see remarkable innovations and treatments bringing life and hope where before there were none. And I also see thousands of people lacking access to basic health care. While the Patient Protection Affordability Care Act will support public health systems and programs on the South Side and elsewhere, we can't get complacent and think that the new health care bill will solve all of our problems just with its passage. We must continue to develop bold and effective ways to meet the needs of underserved populations. We can only achieve these solutions by working on the ground in community, and most importantly, with communities. If we do this right, we will develop a true understanding of the many challenges faced by people with limited resources. By that I mean the financial resources and assets and services available to people in their communities. Understanding how people with limited resources make healthcare decisions will enable us to better help them make good decisions that lead to improved health outcomes. And that's where the University of Chicago Urban Health Initiative enters the picture. A good deal of media coverage was devoted to the insurance reforms addressed by the Act, especially to the provision that insurance companies no longer will be able to deny coverage due to pre-existing conditions. While the insurance reforms are an important aspect of the healthcare bill, they alone will not solve the access problem. At the most fundamental level, we need to develop true systems of care, especially since the health insurance reforms will enable millions of newly insured patients to access care. It is imperative that those patients be well served. The Washington Post observed in a major story in July 2009, and I think the author of that piece is in the room tonight, or this afternoon, that the Urban Health Initiative is trying to produce a major expansion of community care that will improve patient health and reduce cost, goals central to President Obama's healthcare reforms. Reform of our nation's healthcare system will not be complete without improving preventive care, promoting more cost-effective uses of our healthcare system, and helping people in underserved communities get better routine care. The Urban Health Initiative has been working to create the local systems that provide the care prescribed by the Act. Dig deeper into the new law, and you will find a strong emphasis on 3 priorities that the Urban Health Initiative has been working to address since its inception. These priorities are 1, preventative community-based care, 2, incentives for change, and 3, research and data gathering. First, I'll talk about preventive and community-based care. The Patient Protection and Affordability Care Act encourages prevention by removing financial barriers to preventive care. For example, the Act eliminates copays and deductibles for recommended preventive care and screenings, such as cancer screenings and mental health screenings. The Act also provides seniors on Medicare with free annual wellness visits and improves access to preventive services for Medicaid participants. The UHI, the Urban Health Initiative, enables this preventive community-based care to actually happen by connecting people with the doctors and community health centers that provide it. Making this connection, helping people find a doctor they can call their own, and developing a relationship with turns the concept of preventive community-based care into reality. This is important because research shows that individuals who don't have a regular doctor miss opportunities for preventive care, early detection, and prompt treatment. These individuals often wait until they experience some kind of pain or discomfort and then visit the emergency room. At the University of Chicago, we have upwards of 75,000 emergency room visits each year. About 40% of the individuals making these visits, which cost about $1,000 each, have non-urgent problems that can be seen in a community health center where a visit may cost about $100. So for 1/10 of the cost, they receive the added benefit of being connected with ongoing preventive services rather than having only their immediate problem addressed after being triaged in a busy emergency room. The Urban Health Initiative works to make this preventive community-based care possible through the Southside Healthcare Collaborative, a network of 25 community health centers and 5 local hospitals that provide primary care, chronic disease management, and some specialty care. These neighborhood clinics and community hospitals also benefit from this arrangement, and this has to be win-win because they receive increased patient activity and the assistance of U of Chicago doctors at many of their facilities. The federal government provides many of these community health centers special subsidies for providing care to patients with limited or no insurance. The University of Chicago Medical Center, through the Urban Health Initiative, has invested more than $12 million in Southside efforts, including the collaborative. Even with that investment of money, staff, and time, a survey we conducted of Southside residents showed that only 6 of 10 respondents, so only about 60% of respondents, knew that community health centers existed. So we have this gem that's there that people aren't aware of to the extent that they should be. And so it's a long process to change perception and behavior, but the University of Chicago is committed for the long term. For patients who choose to receive primary care through the collaborative, we're working to establish the concept of what the medical community refers to as a medical home for them. As you may have read or heard, the concept of a medical home is gaining many supporters because it furthers the effectiveness of preventive care by providing an ongoing relationship between the patient and provider, coordinated and comprehensive care through a community-based network, and respect for a patient's religious and cultural beliefs. Medical homes also achieve better outcomes. Evidence suggests that patients with a medical home get earlier and more accurate diagnoses, they get better preventive services, they use the emergency room less often, have fewer hospitalizations and drug prescriptions, and also have high satisfaction with the care they receive. All of this at a much lower cost. To date, 50,000 people have been connected to a medical home or specialty care services through the Urban Health Initiative, a very encouraging result so far. And right now, more than 50 University of Chicago doctors are providing care through the collaborative. Our partners on the South Side are making important contributions in this effort. For example, Mercy Hospital, in collaboration with the University of Chicago, admits inpatient psych patients as well as general internal medicine patients. We also have a longstanding relationship for subspecialty pediatric services at La Rabida Hospital. We aspire to create a geriatric network of care for the South Side elderly, and we hope to have, my good friend from Holy Cross, Wayne Lerner, involved in that sort of effort. On the outpatient side, we have started to offer subspecialty care at the Access Grand Boulevard site and have a relationship with Stroger Hospital for pediatric subspecialty outpatients. We are also in talks with Cook County to have our medical center physicians at nearby Providence Hospital. Not only can a relationship of this sort advance the mission of the Urban Health Initiative, it can also revitalize this historic medical facility and bring to it new revenue streams to ensure its healthy, long-term future and to help sustain other parts of the county healthcare system with dollars that might be redeployed elsewhere. So as you can see, we're really trying to connect the dots and do our best to link people to the right care at the right time and place, while supporting and building our partners in the community. This is creating the foundation for a strong, coordinated healthcare network that is truly able to meet the needs of Southside residents. Key to helping patients make the transition to community health centers are patient advocates at our medical center who help patients who come to the ED find long-term solutions for their healthcare needs in the community in which they live. And as part of this effort, we're also training other emergency room staff at local hospitals how to implement this same patient advocate model so they too can make those long-term connections between patients and doctors. Now, those who accuse hospitals of patient dumping when they direct patients away from the ER are too quick to assume the worst. These critics miss the fundamental point that there are a host of reasons why it's good health and fiscal policy for urban hospitals to redirect patients away from hospital emergency rooms and to primary care centers, where they'll receive better care at lower cost to them. And it's lower cost to them, the health system, taxpayers, and everyone who pays the health insurance. In another effort to improve the quality and cost efficiency of care, the Urban Health Initiative is creating a new health grid that uses grid computing technology to improve communication within the collaborative and help patients connect with their doctors from home. This digital infrastructure will allow us to transmit electronic medical records throughout the collaborative. Patients will also be able to administer certain screenings at home and transmit the information to their doctors. Again, it's all about connections. This approach to preventive community-based care is particularly needed and valuable on the South Side, where 1 million people suffer in disproportionate numbers from conditions such as diabetes or hypertension. The hospitalization rate on the South Side for certain conditions, common conditions like asthma, hypertension, and diabetes are 2 to 2.5 times higher than the rate for the rest of Illinois. And the lack of preventive care has resulted in less than desirable outcomes and high costs. By emphasizing preventive care in neighborhood settings, we can change this. Now let's take a look at the second priority that the Urban Health Initiative shares with national healthcare reform efforts, incentives for change. The Urban Health Initiative echoes the President's recently signed act, as well as the health information technology provisions of what's called the Stimulus Act, by creating incentives to improve quality, access, and cost efficiency. Within these newly passed bills, there's a continuation of bonuses for physician quality reporting and new incentives for electronic health record implementation. There will also be pilot evaluations of new and innovative reimbursement models that emphasize pay for performance over payment for task or procedure. For example, the new healthcare reform law establishes a new Center for Innovation through the Centers for Medicare and Medicaid Services that will research, develop, test, and expand innovative payment and delivery arrangements to improve the quality and reduce the cost of care. Innovations that are found to work could then be rapidly expanded and applied more broadly, helping to transform the healthcare system into one that provides better care at lower cost. The Urban Health Initiative, too, strongly believes in offering incentives for change. For example, our REACH program gives financial help to graduates of the university's medical school who choose to practice medicine at a community center or a hospital on the south side within our collaborative. This is a huge incentive because our average graduate from the medical school graduates with, and let me say this slowly, $175,000 in educational debt. And this is when I talked about my wife having more debt than me. This is where that matters because we tend to marry someone like ourselves, and you can have your educational loan payments being more than your house note because of that sort of debt level. This program provides these graduates with the opportunity to experience career satisfaction and a sense of fulfillment immediately upon beginning their careers, when many medical student graduates are consumed in paying off their debt. Also, in partnership with the university's medical school, other campus offices and community partners, we have begun a number of programs that involve medical students and faculty in community service and clinical care. These include student-run community service groups that provide free clinics and health education, a summer service partnership in which medical students pair up with public high school students to work on sustainable community health service projects, community health scholarship track during all 4 years at the Pritzker School of Medicine, and a health disparities course for all first-year medical students. It's important for our students to get beyond the campus to have high-quality educational experiences in community-based settings for two reasons. First, it increases the chance that they will stay on the South Side to practice medicine after graduation. And second, our medical school is one of the top 5 producers of academic physicians. We are a teacher of future medical student teachers. By instilling the importance of community health centers in our students, they in turn will pass that value to their students into the future. And the third priority that the Urban Health Initiative has in common with national health care reform is research and data gathering. Again, take a closer look at the health care reform bill, and you will find a strong emphasis on measurement through data, especially as we evaluate new and promising models of care that may improve healthcare quality and contain cost. Only by gathering and evaluating data will we know whether or not healthcare reform efforts are working. Data gives us an understanding of what determines health, both positively and negatively. To take the right steps to meet the urgent needs of the community, we need data. To understand whether or not our programs and interventions are making a difference, we need data. Without data, we are working in the dark. Even with data in hand, it's important. It's only important if we use it to inform public policy, develop new health programs, or track outcomes of existing programs. In the spirit of using data as a powerful tool to improve community health, the Urban Health Initiative established the Center for Community Health and Vitality. This center is early in its development, but will track and integrate the university's community studies. Essentially, we'll find ways for faculty researchers to partner with communities to meet local healthcare needs. The innovation here is that the community will have a co-equal role in setting the agenda for the center, as opposed to academics deciding what is good for the community. As part of this center, we launched the Southside Health and Vitality Studies to gather and measure the effectiveness of our efforts. This project connects U of C medical, health, and social science researchers with community organizations and residents. Their goal is to better understand factors that influence individual and community health and to propose effective ways to translate their findings into action. Through the Southside Health and Vitality Studies, we'll implement long-term focused studies tracking individual and household health over a generation in 34 of the Chicago's 77 separate community areas. This effort will generate a baseline of data to drive informed policy and healthcare decisions. And we actually have one study that's already well underway, and this needs a better name, but it's called the Real-Time Community Resource Mapping System. See, not exactly snappy, but it is important in that it's a comprehensive census of commercial, healthcare, social, and civic resources on the South Side. And you can browse the first phase of the system on a website, www.southsidehealth.org. Let me repeat that for all of you here, www.southsidehealth.org. The South Side is an area rich in community traditions and resources. These resources can be positive factors that can play a substantial role in promoting good health and wellness. And we've done all of this work over the last 3 years, and we've gotten a great deal of interest from local community-based organizations and also our local political leadership, because they see what we want. And we want actionable, action-oriented data that we can use for the purpose of improving health. We've also attracted a lot of attention and interest from what we're doing from urban hospitals across the country, and we're excited to share what we're learning and what we're doing with them. The Urban Health Initiative is a win-win proposition. Patients get better care in neighborhood settings and get better connected long-term to a doctor who knows them, tracks their health, and helps them prevent or manage conditions before they become critical. The University of Chicago Medical Center can better focus its resources on the care of patients with complex medical conditions requiring extensive expertise and high technology. Our emergency rooms can focus on providing rapid care for real emergencies, and overall our society benefits by the reduction of healthcare costs currently weighing down our businesses and economy. And that brings me to another aspect of healthcare reform that needs to be emphasized, how it begins to fix a broken national system and how reform will benefit not only the underserved populations I talked about, but it'll benefit everyone in this room, all of us. When large portions of our population goes without insurance or adequate medical care, it winds up increasing costs for all of us, and it also winds up increasing our insurance premiums. Right now, it's estimated about 30% of the health care-related premiums and bills you pay go towards covering the cost of people who don't have health insurance. Furthermore, the financial strain this places on healthcare providers can wind up degrading the resources available to everyone, even those with insurance. For example, when a hospital cuts resources due to the financial burdens of treating the uninsured, those cuts affect every patient that enter a hospital, not just uninsured patients. So if a hospital can no longer afford to have a neurologist on call or a second neurosurgeon on call, that affects everyone with a brain injury, not just someone who has no insurance. For example, on the south side of Chicago, we had the closing of Michael Reese Hospital, which greatly reduced healthcare services for all of the south side, not just for those who are underserved. Now, thanks to the healthcare reform bill, most people will have insurance and be part of a risk pool, spreading the cost of those needing care more evenly and fairly across our population. Also, thanks to healthcare reform, we don't need to worry about our kids, especially those who have chronic illnesses, being denied coverage when they're older. And we can even choose to keep our kids on our insurance policies now until they're 26. And that should be a hallelujah in this crowd right now. The provisions regarding pre-existing conditions that I mentioned earlier dispel these worries. And thanks to healthcare reform, no longer will you or your children or your friend or extended family members need to worry about getting into a situation beyond your control where you have a serious illness and no healthcare benefits. Healthcare reform reduces the chance that you, a friend, or a family member will be driven to bankruptcy due to medical costs, a leading, if not the leading, contributor to bankruptcy. How we as Americans respond to the needs of the sick and poor is a character test for our nation. In March, we passed an initial test. There will be more to come. Cries of repeal are already out there, primarily due to the cost of the investment we must make in healthcare reform. But as President Obama has said many times, the status quo is even more expensive for the reasons I have outlined today. Still, making sure healthcare reform works as intended requires our vigilance and attention. As we provide care to increasing numbers of Americans, we must also work to make healthcare more efficient and gather data that tells us whether or not what we are producing it has the results we desire. Then we must continually use this data to make needed adjustments and improvements to what we're doing. So in summary, I want to emphasize that I strongly believe the historic passage of national healthcare reform is going to change health outcomes for the better in ways that directly impact people, our communities, and the economy as a whole. I'm proud to say that the Urban Health Initiative, hand in hand and shoulder to shoulder with our many partners on the South Side, is taking a lead on the very priorities outlined as part of this national reform. To know that what we've been and are continuing to do here in our own backyard is now in sync with our country's national efforts give me hope and optimism that we're going to achieve real change in how all populations, especially underserved ones, can better access health care services. Yet, there's much work to be done. There always is. But together, I'm confident that we're going to improve the health of our communities and make a real difference in people's lives. Thank you for listening and for your attention to the issues I addressed today. I stand ready to respond to sensible questions. Mind you, I said sensible. Because you know there's some outrageous questions out there that I won't even consider.
Well, I'll try to screen out a few craziness, best I can. But send your questions up. I only have one so far. I'm sure there's people out here that want to have several more. Oh, here we go. Wonderful. Well, we're going to start out with one of our own Board of Governors, Joyce Saxon. She says, was there anything omitted in the bill? What important clause, in your opinion, possibly was omitted?
I think the important thing about the bill is that it is a start. What I want us all to do is pay attention to the detail, because a lot of the rules and regulations are being written outside the eye of the public. And this is where, people who advocate for patients and for those who are on the right side of things need to be very active. And so I wouldn't say that, I think that the bill is a broad template that gives a lot of opportunity for a lot of great things to happen. But, the devil is always in the details. And so we just need to make certain that we pay attention as those details are being shaped, in offices and committee rooms that may not be where the cameras are.
Thank you very much. We have another question. It's from Dave Lundy. And this is, what was the most effective method for fighting H1N1 flu in minority communities? Follow up, did the communities do better than past health crisis?
I'm trying to decide, is this a sensible question? But we'll consider it. I think the issue. The issue here, I think, with H1N1, which I had the pleasure of working with many people across the state to get our state prepared for H1N1 over a long period of time, for probably 4 years. We, in fact, were of states in the country, we ranked in the top 7 in terms of preparedness for bioterrorism and natural events. And we have a lot of folks throughout the state who work with me to make that happen. What we found in doing that work and learning from the experience of others is that we need to, not unlike we're talking about with the Urban Health Initiative, we need to really start and do the work at the community level. I couldn't be in my office in Springfield dictating policy for what would happen on the ground. And one of the lessons we learned from Hurricane Katrina is that when people were in crisis, that we had all these public health folks who were there, trained, and the folks who were on the ground themselves ran past all those folks to go to people like Reverend Ryan, the people with the collars. The folks in their community who were in churches and other places that they knew. And so, one of the things we found effective, and we're replicating this in the Urban Health Initiative, is trying to make a good use of the faith-based community, because a lot of times that's where communities, when they're in crisis, that's where they turn. And so, I would say that, as you looked across the country, our work in this particular area was recognized by the CDC as being an important innovation for improving the health of minority populations. Now, that's come under some controversy as of late, but I stand by the fact that the churches on the ground are important actors in communities with ministers who are opinion leaders and have a lot of sway. And we have to work in conjunction with them to not only prepare ourselves for H1N1, but for any number of chronic diseases that are causing problems for the United States and in fact, the world. I mentioned I was in Davos, Switzerland, and in the developing world, typically, the sort of things that people have been worried about have been infectious diseases, malaria and that sort of thing. But now for the first time, they're worried about chronic diseases, things like diabetes, hypertension, and that sort of thing, and identified that chronic disease is one of the top 5 global challenges in the world. So to the extent we can figure out how to do innovative things with particularly vulnerable populations, we can not only affect health in this city and on the south side, but we can actually develop models that can be taken from the south side to Tanzania and have an impact globally.
As a moderator, I have a question for you. Okay. I was looking at the paper last couple of weeks, and it was announced that the Office of National Drug Control Policy made mention that they were reforming their policy around alcohol and substance abuse problems or addiction healthcare, and saying that, in essence, that the administration wanted to put more emphasis on addictions as a healthcare problem as opposed to a law enforcement problem and an interdiction problem, that type of thing. And as I listened to your comments today, which I think are wonderful, by the way, Dr. Whitaker, wonderful with the work that you're doing with the Urban Initiative, I was thinking about the disproportionate number of African Americans and Hispanics who are impacted by addiction healthcare issues. And I heard you mention something about some mental health collaborations you're doing with one of the hospitals. I was wondering if there's room at the table for community-based providers to partner with the Urban Initiative around addictions healthcare, which is disproportionately, obviously, impacting our communities.
You make I'm going to take the liberty of saying what I think is salient about your question. One, we have to approach health in a holistic fashion. And we haven't done that. We've even within medicine, we've chopped things up by body part. So, you got a kidney doctor, you have, a heart doctor, you have all these different doctors. And even within medicine itself, we've specialized in and haven't paid attention to the whole person. I think also, to extend that comment, that thread, we need to care about the mental health, which we haven't done as well as we should have. And in fact, there's been a number of laws that have advocated for mental health parity to treat the physical and mental health along the same pathway. In terms of the Urban Health Initiative, I have a simple rule that, I work with whoever raises their hand and says, that they want to be a part of it. We've done some initial work around mental health on the South Side, and there's a paucity of mental health providers. And as you talk about substance abuse, it may be even worse for substance abuse, but clearly that's an issue that is important for a lot of the people on the South Side. And if we're going to make some progress, we have to start thinking about mental health and substance abuse in a way that's holistic and not apart from the way we think about medical services.
Thank you so much. Thank you so much, Dr. Whitaker. It's been a wonderful presentation. I'm sorry, we have one more, certainly. All right. Is it crazy or not? How will the HCI, Healthcare Initiative, or I'm sorry,
Is that UHI or what? Is that?
HCI?
I'm not sure.
Involvement in providing patient services affect the participating hospitals, for example, their current programs, resources, et cetera.
Okay. We'll name this as a question to be answered, okay? First of all, let's get that out of the way. You know, the Urban Health Initiative, one of the things that we're very clear on is it has to be collaborative. For example, some medical centers take the stance that they need to own everything as they try to do things. So we didn't go out and say, let's buy up a lot of practices and hospitals to get this work done. And we're very mindful, and in fact, I think with the Urban Health Initiative, we've become more mindful about the impact our medical center has on other people. And why is that important? Because, you know, maybe about 7 years ago, we ended up expanding all the general care we were seeing in our hospital. And as a consequence, we were sucking patients out of other hospitals that were nearby. And that's critically important because, you know, when I started medical school at U of Chicago in '87, since that time, we've seen, I think, 7 hospitals close on the south side of Chicago in that period of time, where there's a profound need for a lot of hospitals. So we go into this mindful that, first of all, we can't do all of the care on the south side. We only, at the University of Chicago, see about 10% of the patients who need service on the south side. And if you're a public health person, what that means is that there's 9/10 of people who don't show up at your door. And if you want to improve health status, you have to work on improving health and work collaboratively with all of where the places these other 9/10 of people show up. And so we're trying to work together collaboratively, strengthen the network of providers by sending patients to them that they financially can work with, and that's been a good collaboration. You know, I think that if you talk to some of our partners, you know, they've benefited from it, and I'm very mindful again that it has to be a win-win situation. If we work with Provident, if we work with anyone else, if the University of Chicago wins everything and the partner wins nothing, that's not sustainable. And we're in the business of having sustainable partnerships that last not only this decade, but the next one. So you know, I think there's a great deal of promise for working with other folks and letting people do the things that are in their sweet spot of experience while we focus on the things that are in our sweet spot of experience.
Again, we want to thank Dr. Whitaker for a wonderful presentation. Excellent. This is what you can